Hello students, today we're going to be reviewing the structure and function of the anatomy around the foot and ankle. So just like before, you may want to get the lecture notes, you may want to print out the slides or be able to view them just on the computer here, but kick back and let's get ready to go. We're going to start actually a little bit of a distance away from the foot and ankle and look at the proximal or superior tibiofibular joint. And this is an articulation, just like it sounds, between the tibia and the fibula, and it's on the proximal end of the tibia. And the reason we're looking at this here is it's not at all involved with the knee joint capsule. The fibula actually serves as a strut or a support all the way down to the foot and ankle structure. So I'll slide there in a second, but you can see here that it's not a synovial joint, it's a fibrous joint. It's got good ligamentous stability with the anterior and the posterior longitudinal or posterior ligaments, but then there's also, remember, the lateral collateral ligament also attaches to the head of the fibula, so it contributes to the stability there. So if you look here, you can see the fibula serves as a long strut all the way down, because on the distal end, of course, it's going to be forming a portion of the mortise for the talocrural joint. So we certainly wouldn't want any movement to occur either at the distal or the proximal end so that the ankle is stable. So again, not really a lot of function here, a little sliding and gliding during weight bearing and during motion, but we certainly don't want that joint disrupted. So our inferior tibiofibular joint or distal tib-fib joint is at the other end, and again, just a fibrous joint stabilized with anterior and posterior tib-fib ligaments. We also see the interosseous membrane spanning the length of the fibula, between the fibula and the tibia, and that also contributes to the stability and the force transmission between those two bones. This little window pane here, this is a nice little view of the tibiofibular joint, kind of more from the inside, and again it shows the concave portion of the talocrural joint and how that's formed with the fibula abutting the tibia. So let's go to the talocrural joint then, of course, is that mortise is going to sit on top of this talus here. And we can see that both from a lateral and a superior view. I'm going to go forward one more. And so now here's our mortise sitting, and the tenon is sitting within the mortise. So this is the mortise and tenon joint. Remember, that's an old carpenter term. You might see that if you look in some drawers, you'll see mortise and tenon or dovetail joints. Same kind of thing. Just looks like a little press fit in there. And in open chain, of course, the talus is going to move on the tibia and the fibula, so that's going to be convex and concave. What's the arthrokinematic relationship? Which way is the articular surface going to go if the foot comes dorsally upward into dorsiflexion? Right, it's going to roll forward, but it's going to slide back. And then similarly, when we go into plantar flexion, the foot's going to be going back, and the dome of the talus here is going to be sliding, or the trochlea of the talus is going to slide forward. You can see here the superior view that the anterior aspect of the dome of the talus is wider, or the trochlea of the talus is wider than the posterior side. Dome and trochlea are synonymous terms, is wider. And so what we see when somebody does go into dorsiflexion, this wider part of the talus wedges between the medial and the lateral malleolus, puts a little stress on there, and that's part of why dorsiflexion is the close packed position, because it does kind of wedge in there and it's the more stable. That's certainly very helpful for us in normal stance when we are at least in neutral or maybe leaning forward a little bit into closed chain dorsiflexion. Moving on, we're going to look at the subtalar joint. And subtalar, of course, underneath the talus. And with that joint, the motions there are pronation and supination, but we're going to go ahead and just say that they're synonymous with inversion and eversion. We know that from kinesiology that pronation has eversion as one component and supination has inversion as one component, but I think in normal speak every day we do use those terms synonymously. You'll want to be comfortable with both, but I'm happy with you interchanging them. So if we look at the medial aspect of the ankle joint for the ligamentous structure, this is where we see the deltoid ligament, and there really are three portions of the deltoid ligament, coming down to navicular tuberosity, down to the sustentaculum tali, and back to the medial tubercle of the talus. But it's really one big fan-shaped ligament, hence the name deltoid, fan-shaped. And it creates a lot of stability on the medial aspect of the foot and ankle, and it prevents eversion from occurring at the subtalar, and you're going to see also at the transverse tarsal joint. The lateral side of the ankle is a whole other matter. Here we have three very separate ligaments, and since they're not connected to one another or spanning the whole area, there's much less stability on this lateral aspect of the foot. So we have our anterior talofibular ligament. This not only limits inversion but also plantar flexion. I think you can picture if the foot was going to go down into plantar flexion that would elongate. There's the calcaneofibular ligament. This does limit just purely inversion. And then, of course, the posterior talofibular ligament posteriorly here is going to limit inversion, but then also dorsiflexion. So I think if you picture the foot going in dorsiflexion, you may be able to visualize how that gets tight. These are the ligaments that generally are injured when we have an ankle sprain. Closed pack position for the subtalar joint is supination. And if we go to the transverse tarsal joint, same motions essentially occurring here. And there is a lot of complexity in the mechanics of the foot and ankle between the subtalar and the transverse tarsal, and we're not going to go into that great depth, but it would be good if you went back to kinesiology and maybe reviewed the axes of motion, how they go through those joints, and particularly how muscles create either inversion or eversion in relationship to those joints. But the transverse tarsal really goes across two articulations between the distal end of the calcaneus and the proximal end of the cuboid, and then the head of the talus. So here's the head of the talus articulating with the proximal end or proximal surface of the navicular. Same motions that occur at the subtalar joint occur here. So we have pronation and supination, and when you're standing on your foot, you can also kind of shift your weight to the lateral aspect or to the medial aspect of the foot, and the arch will raise and lower, and much of that motion is occurring here at the transverse tarsal joint. Closed pack position again is supination. If we go on, we can see the tarso-metatarsal joints, and nothing really too spectacular about these, and just mostly gliding and a lot of accommodation to different surfaces. So this kind of accommodates and allows us to keep our foot maximally in contact with uneven surfaces. MTP, metatarsal phalangeal joints. We technically have both flexion and extension as well as ab and adduction, though it kind of varies on how much people actually have motor control and can do ab and adduction of their toes. But those are the motions that are occurring at the MTP joints. And then finally the IP joints. There's only one IP joint at the great toe, of course, but then proximal and distal IP joints, just as in the fingers, are in the toes. They're a lot tinier and a lot closer together, especially when you get to that fifth digit. These are hinge joints, of course, and they only have flexion and extension. So let's review the arch system of the foot a bit. Of course, from the medial aspect, we have the medial arch, and that's going to be the springy one. This is the one that we need for shock absorption. That's going to basically run from the calcaneus all the way up and through to the heads of the metatarsals. We see here we have the planto-calcaneo-navicular ligament. Do you remember what that one's, what do we always call that ligament? Just one short word. Begins with an S. The spring ligament, right. So look what's sitting right here. So the spring ligament is spanning over the transverse tarsal joint, right where the head of the talus is meeting the navicular. So when we see people who have fallen arches or a pronated foot or a diminished medial arch, we often see that the head of the talus is down further. It's kind of slipped down because it doesn't have this ligament to hold it up. And that's really one of the very first pathologies we're going to be looking at when we do pathologies, is to look at the different elements of the different changes that can occur in the arch system of the foot. There is a lateral arch system. It's not nearly as high. It's very rigid, so we don't have the flexibility, and we don't typically worry too much about that. And then we have also a transverse arch at the heads of the metatarsals. That is also flexible, and that gives us some ability to contour to different areas and to absorb force. If we look further on the plantar aspect of the foot, we see further supports for the medial and lateral longitudinal arches. We see the short plantar ligament, and that's deep to the long plantar ligament. So short plantar ligament running from the distal end of the calcaneus over to the cuboid, long plantar far more proximal on the calcaneus all the way up to the the bases of the metatarsals. And then here's that spring ligament. It looks a lot broader from this view, right? Remember from the lateral view how really narrow it looks? But from the plantar aspect, it really is covering the entire, it's kind of hammocking the entire head of the talus and really supporting that. And again, finally, from the side view then, here's the spring ligament, here's the short plantar, here's the long plantar ligament. And, short plantar, long plantar ligament, and then the plantar aponeurosis. And let's look at that more in this view, starting from the medial tubercle on the talus, and it's going to extend. Its big, thick connective tissue extends all the way up past the heads of the metatarsals to insert in the bases of the proximal phalanges. And this is important because when we deal with pathologies like plantar fasciitis and we have to stretch this fascia, we have to recall that it's crossing the MTP joint, so we have to incorporate MTP extension as well as ankle dorsiflexion to get a good stretch. So let's look one more time at this lateral view. So we really see this sequential support. We have this very up close and personal support of the medial arch right under the head of the talus. Then we've got the short plantar ligament, the long plantar ligament, and then extending the full length of the foot up through, you can see it really nicely, the attachment to the base of the proximal phalanges, the plantar fascia or plantar aponeurosis. Those terms are synonymous. Let's shift now and start looking a little bit at muscles. You know, I like these cross-sectional pictures, and if we look at the lower leg, we're looking right through the cross-section here, transection here at the calf. Of course, posteriorly is going to be the biggest muscle group, and that's going to include primarily gastrocnemius and soleus, but we're going to see a few other muscles in there. And then we have the anterior or anterolateral, anterior and lateral compartment of the leg. So we've got the dorsiflexors, and then on the lateral side, the peroneals. So that kind of gives us our general orientation. So let's look more specifically. We'll start with the muscles that contribute to dorsiflexion. Of course, the biggest one that gets all the press is tibialis anterior, and that's coursing down and then crossing to the medial aspect of the foot. So that's going to be the big and most medially oriented tendon on the dorsum of the ankle. Does dorsiflexion and inversion both. The next one over, right next to it, is extensor hallucis longus. That one you had to muscle test back when we did the spine. How come? What innervates the extensor hallucis longus? Right, L5. So it's a little canary in the coal mine for L5 impingement. Lateral to that is extensor digitorum longus, and that's going to come down and attach to a common tendon is right here over the talocrural joint, but then it's going to split and attach to each of the 4 lesser toes. And then the last dorsiflexing muscle is a tiny little muscle called, in this case it's labeled Fibularis tertius. We, in our language, usually call it peroneus tertius. So you may see it labeled Fibularis. Of course, it's attaching to the lateral side on the fibula, but peroneus tertius is how we described it. Posteriorly, for plantar flexors, as I mentioned, the biggies are the gastroc and soleus, though you're going to see there's a couple other muscles certainly that contribute to plantar flexion. If we look at inversion, we have the tibialis anterior, which we looked at before, and then we have tibialis posterior, and then we have flexor digitorum longus, flexor hallucis longus. Those are all coursing behind the medial malleolus and going to the plantar aspect of the foot. In the order of those tendons, we use the acronym Tom, Dick, and Harry for tibialis. The D is digitorum, and then the H, flexor hallucis. And we'll be looking at tarsal tunnel syndrome as one of our pathologies today, and we'll kind of revisit the organization of those tendons. Again, they all do inversion, but they are also, since they're behind the malleolus, they all do plantar flexion as well. And then our everters, we always think about our peroneals as our everters. We have, again, this is labeled as fibularis, but we would call it peroneus longus, peroneus brevis, and remember, even peroneus tertius, even though it was considered a dorsiflexor, it's also on the eversion side. And peroneus longus and brevis, of course, coursing behind the lateral malleolus, so they are going to also contribute to plantar flexion. From an innervation standpoint, we're looking at 2 basic nerves. You can see here the common peroneal nerve, again instead of fibular nerve, coming around, coursing behind the head of the fibula, and that's going to innervate the dorsiflexors and the everters. So if we have damage to this peroneal nerve, we're going to lose both dorsiflexion and eversion. And then what's the name of the nerve that courses behind the knee and innervates the plantar flexors? Comes down from the sciatic nerve, splits, behind the knee, right, tibial nerve. So the tibial nerve is innervating the plantar flexors. That wraps up our anatomy and structure review for the foot and ankle. If any of this went too fast, or if it kind of tickled a few memory cells but you want to look in more, then I would definitely encourage you to go back and cruise through your kinesiology book or your trail guide book again and make sure you're really comfortable with the muscles and their actions so that when we move into exercises, you're ready to go. All right, I look forward to seeing you in class. Thanks.